Okay, so we're going to do chapter 17, cardiovascular emergencies. We've actually talked a lot about this in class and on other chapters, so it shouldn't be too bad. Um, so we're going to discuss respiration and perfusion and patient assessment and management. Trying to get my computer to work here. Um, Cardiovascular, the anatomy, signs, symptoms, and management of chest pain and cardiac arrest. Um, Anatomy, physiology, pathophysiology, assessment, and management of acute coronary syndrome, angina pectoris, myocardia infarction, and the aortic aneurysm or dissection, thromboembolism, heart failure, hypertensive emergencies. So cardiovascular disease accounts for about one in every three deaths. EMS can help reduce death by providing the following service. So, encouragement of people to follow a healthy lifestyle, early access to medical care, um, more CPR trained training of the layperson, everyday people getting CPR trained, and increased use of involving technology and dispatch of cardiac arrest response. Once again, you've heard me say it, the more we educate, the better off we are. So we need to education's a huge part of EMS, so we need to be educated enough ourselves that we can educate others. Public access to a defibrillation device, the AED, recognition of the needs for ALS, the use of cardiac specialty centers when they're available. So, anatomy and physiology. So, the heart's job is to pump blood, oxygenated blood to the cells and tissue of the body and then return unoxygenated blood to the heart where we can reoxygenate in the lungs, um, which we learned about in chapters 11 and 16 on respiratory. The heart's divided down the middle into left and right sides, each with an upper and lower area. So your uppers are your atriums and your ventricles are your lowers. Um, So upper right, and we'll see a diagram in a minute, but upper right atrium receives blood from the body. It's then pushed into the lower right ventricle. It then goes from your right ventricle to your lungs through your pulmonary artery. From your lungs, it goes back to the heart through your pulmonary veins to the left atrium down to your left ventricle, where it's then pumped up through your aorta to the rest of your body. So it comes in the right side unoxygenated, it leaves the left side oxygenated. So we've got our vena cava, superior, inferior. We have our right atrium, tricuspid valve, left or right ventricle, pulmonary arteries right here, which go to our lungs. Comes from our lungs back through a pulmonary vein into the left atrium, through the mitral valve into our left ventricle. From our left ventricle, it's going to come up uh, to our aorta and be pumped out through the body. So, like I said before, the right side is unoxygenated. It goes to your lungs, and then the left side is oxygenated and it gets pushed up to the body. Um, One-way valves keep the blood flowing in the proper direction. The aorta, the body's main artery, receives blood ejected from the left ventricle. So if you can follow the arrows on the diagram, it kind of shows you um, the flow of blood. I'm trying to get my mouse back on my computer here. Okay, I guess it doesn't matter. So blood's coming in through our inferior vena cava and our superior vena cava into that right atrium, where it is then pumped into the right ventricle. From the right ventricle up to our pulmonary arteries to the lungs. Jump over here on this side, it returns as oxygenated rich blood through the pulmonary veins into that left atrium, where it is pushed into the left ventricle, and then to your aorta, where it supplies the body with oxygenated blood. So the heart pumps using an electrical system. This controls the rate and coordination, atria and ventricles. The electrical impulse starts with our SA node. It's our built-in pacemaker, if you will. It applies a small electrical charge, which causes the muscle to contract and relax. That is the heart pumping. Automatically allows spontaneous contraction without stimulus from a nerve source. So there's just a small diagram. You've got your SA node. If something goes bad with your SA node, your AV node will pick up and kind of it's your backup. It will not produce the same amount of electrical pumping activity as your SA, but it will give you a heartbeat long enough for you to go get like a pacemaker put in. Don't quote me on these numbers. SA node will allow 60 to like 120 beats, where your AV node is going to be like 40 to 60 or something. So your SA node is more electrical conductive than your AV node. You've got your pathways. It's no different than the electric current in your house or anything else. There's got to be, um, there's got to be some sort of electrical line for it to follow. It's an electric current. And that's what those are. And then you get your bundle of his, and then it divides into that right bundle branch and your left bundle branch. And then it goes on further down to your Purkinje fibers, and your left anterior fascial. I never can say that right, but the main thing you need to know is that the SA node produces your electric current, and that you do have an electrical system in your heart that produces that pumping action. Autonomic nervous system, your ANS controls involuntary activities. The autonomic nervous system has two parts: your sympathetic nervous system and your parasympathetic nervous system. The myocardium must have a continuous supply of oxygen and nutrition to pump blood. Cardiac output is increased by increase of heart rate and stroke volume. In the normal heart, increased blood delivers the myocardium by dilating with the coronary arteries. So the coronary arteries are blood vessels that supply blood to the heart muscle. They start at the first part of the aorta, just above that aortic valve. The right coronary artery supplies blood to the right atrium and right ventricles, and in most people, the inferior wall of the left ventricle. So the left coronary artery supplies blood to the left ventricle, and the left ventricle and divides into two major branches just a short distance from the aorta. So here, this diagram, A and B. So A is the anterior view, so it's the front side of your heart. B is the posterior, the back side of your heart, um, which is kind of good because you'll notice the difference there. Like we can see that left atrium well, you can see the pulmonary veins on the back side a lot better. You get an idea of your pulmonary arteries, and it also your descending branch, coronary artery, your carotid veins, they wrap all the way around the heart. And we'll get into this here in a little bit when we start talking about emboli. when there's a blockage, what part of that heart is suffering. And then blockages might be on the smaller parts. It might be a major block. When a block happens, part of that muscle dies, and that muscle cannot contract if it's dead. So that's when we're going to start having problems with ejection factors and the amount of blood being pumped. Arteries supply oxygen to different parts of the body. So right and left carotid, right and left supraclavian, brachial, radial, and ulna, right and left iliac, the right and left femoral, and anterior and posterior tibia and peroneal. Arterioles and capillaries are smaller vessels. Capillaries connect arteries to venules. Venules are the smallest branch of the vein. Venial cavia return deoxygenated blood to the heart. Vena cavia. I can't speak today. Blood consists of, so we've already discussed this in other chapters. So we got red blood cells, which carry our oxygen. We've got white blood cells. Those fight infection. Those are your warrior cells. Platelets, they build blood clots. That's how you form a scab whenever you get a cut, is it's those platelets gathering together. And then plasma, which is the fluid cells float in. Um, Remember, when we're talking about this, that aspirin or ASA is not a blood thinner. It actually prohibits platelets from being able to clot. Um, it makes them platelets where they won't stick together. So that's what aspirin does, is it takes away the ability for platelets to clot. Blood pressure is the force of circulated blood against the arterial walls. So we know our systolic blood pressure is the peak. It's the maximum pressure generated by that left ventricle whenever a contraction happens. And then diastolic pressure is the pressure against the artery walls when the left ventricle is at rest. So systolic, diastolic, in that left ventricle is what we're measuring. Pulse is left. Pulse is felt when passing through the artery during systolic. Um, so that pressure emitted on the arteries itself is the pulse. Peripheral pulses are felt in the extremities, while central pulses are felt near the body's trunk. I'm going to go back for a minute. So your peripheral pulses, your radial and posterior tibia, while central pulses, that's going to be something like your femoral or your carotid. So there are some of your pulse points. Carotid, brachial, posterior tibia, femur, radial, and dorsal pedis. Cardiac output is the amount of volume of blood that passes through the heart in 1 minute. Perfusion is the constant flow of oxygenated blood to the tissue. And if perfusion fails, cellular and eventually patient death occurs. We talked about shock a couple chapters ago. Um, Hypoperfusion, so low oxygenated blood um, feeding that cells and tissue, right? So that's what shock is. Um, Chest pain. So this is the pathophysiology side of it. Chest pain usually stems from ischemic, which is a decrease in blood flow. Ischemic heart disease involves the decreased blood flow to one or more portions of the heart. If blood flow is not restored, the tissue dies. It's super important to understand that when we're not getting oxygen to that cardiac muscle will die. Portions of it can die and your heart still work, but it's unable to beat or cycle blood like it should if part of it is injured. Atherosclerosis is a disorder in which calcium and cholesterol builds up and forms plaque inside the walls of the blood vessels. It can cause complete occlusion or blockage of the coronary artery and other arteries in the body. Fatty material accumulates as a person ages, resulting in the narrowing of lumen. Uh, the inner wall of the arteries becomes rough and brittle, so it's hardening of the arteries. There we go. Um, if a brittle uh, plaque develops a crack from unknown reason, the ragged edges of the crack activate the blood clotting system, resulting in a blood clot that will potentially or completely block that lumen. So what it's saying is if we've got like up here narrowing of the arteries, if we get a crack in here and blood starts collecting in it and starts building up, that's when you're going to get that blood clot. Thrombosis, um, thrombus embolism is a blood clot that floats through the blood vessel. If it reaches an area too narrow to pass, it stops and blocks blood flow at that point. Tissues downstream from the blood clot will suffer from hypoxia. If too much time passes before the blood clot is or blood flow resumes, the tissue will die. This sequence of events is known as an acute myocardial infarction. It's a classic heart attack. The death of the heart muscle can severely diminish the heart's ability to pump, which is what we're talking about. It takes a small part of that heart, especially in that left atrium. If that muscle starts to die, we are not going to be able to pump blood efficiently. Um, so these emboli will block blood flow. If there's no blood flow, there's going to be death of cells. When there's death of cells, it's death of tissue and muscle. Therefore, we will eventually have that classic heart attack or that myocardium infarction. Coronary artery disease is the leading cause of death in the United States. Controllable AMI risk factors. So people who cigarette smoking, high blood pressure, high cholesterol, diabetes, lack of exercise, and obesity. These are all things we can control by having a healthy lifestyle. The uncontrollable factors, old age, family history, arthrosis, I can't say it now, coronary artery disease, building up of plaque, hardening of the arteries, race, uh, ethnicity, and being male. So different races, different cultural backgrounds, and a lot of times being a male will play a role in this. Acute coronary syndrome is caused by myocardial ischemia, angina pectoris, um, acute myocardium infarction. So angina pectoris occurs when the heart needs oxygen, exceeds supply. Um, Crushing or squeezing pain does not usually lead to death or permanent heart damage. Should be taken as a serious warning sign. So the reason it doesn't always lead to death or permanent heart damage, there is stable and unstable angina. Angina is chest pain. That's what that stands for. So stable angina, um, when we start having chest pain and we go sit down or slow down and it gets better, that is a stable angina. Something made it better. If we're outside working and we have severe chest pain, shortness of breath, and we go in and we sit down and we take a nitro and nothing helps, that is unstable angina. Um, Stable angina, I took my nitro and it made it better. Stable angina. So when we're doing our questioning, does anything make it better or worse? That plays into cardiac events of stable or unstable uh, chest pain or angina. I'm sorry. So there's the unstable occurs in an absence of significant increase in oxygen demand. Stable angina occurs in response to exercise and activities that increase demand on the heart muscle. Treat angina patients like it's a acute myocardial infarction. We still have to treat it. Um, let's go ahead and put those people on oxygen. Let's go ahead and put them in a position of comfort, cover them up, maintain body heat. Vitals are very important. Let's get a blood pressure. Let's get a blood sugar. Let's watch that pulse. Take care of those ABCs like always. AMI, pain signals acute death of cell in the heart muscle. Once dead, cells cannot be revived. Clot busting, these are drugs or angioplasticity within the first few hours prevent damage. Immediate transport is essential. So if we have someone we believe is having a heart attack, there's usually that clot somewhere in there, and they can give them medication that will go in and actually break those clots up, or they have to go in and put a stent in or remove that clot, do open heart surgery. Um, these people, there's only so much we can do for them in the back of a truck. Um, about 30 minutes after blood flow is cut off, some heart muscle begin to die. After about 2 hours, as many as half of the cells in the area may be dead. After 4 to 6 hours, more than 90% of those cells are dead. Um, hang on, I'm trying to get back to my notes here. I gotta try to find mine. Well, I can't get my cursor back on my computer screen. It's stuck up there on my TV. Um, these are the people that are candidates. They've got to get to a cath lab quickly. Signs and symptoms of an AMI. So we're going to have that weakness, nausea, sweating, chest pain, discomfort, or pressure, lower jaw, arm, back, abdomen, or neck pain, irregular heartbeat, or even syncope episodes, so fainting, shortness of breath, which is dyspnea, nausea, vomiting, pink frothy sputum, or sudden death. Um, keep in mind, read your chapters. Women will a lot of times present differently than men will. Uh, women might be able to hold out longer. They're gonna probably complain of maybe lower back pain or abdominal pain, where a lot of men will have that chest pain, shoulder, jaw. Um, so read your patient, read your signs, get that thorough history. Something might point you in the right direction. AMI pain differs from angina pain. It's not always due to exertion. It lasts 30 minutes to several hours, not always relieved by rest or nitroglycerin. AMS pain or AMI patients may not realize they're experiencing a heart attack. So this would be unstable angina. Um, if it doesn't get better when you change what you're doing, or you take meds and it doesn't get better, that's going to be that unstable angina. AMI and cardiac compromise physical findings. So fear, nausea, poor circulation, fast, irregular, or bradycardic pulse, decreased normal or elevated blood pressures, normal or rapid and labored respirations. Patients express feeling of impending doom. These patients, if they say, I am dying, believe them. There's no explanation for it. If they truly feel they're dying, they probably are. So you just need to be prepared for rapid transport, and we need to treat these patients per protocol. Um, three serious consequences of the AMI is sudden death, cardiogenic shock, and congestive heart failure, CHF. Dysrhythmia, heart rhythm abnormalities, so permanent ventricular contractions, tachycardia, bradycardia, ventricular tachycardia, ventricular fibrillation. Defibrillation restores cardiac rhythm, can save lives, initiate CPR until a defibrillator is available. Then you've got absence of all heart electrical activity, reflex, a long period of ischemia, and normally all patients will die. This is the flat line. Um, Defibrillation is key. Um, it doesn't always mean you're going to get the save. It is a huge, huge advantage to have that defibrillator, CPR. So we've got to follow that chain of survival that we learned in CPR class. Um, but just because you defibrillate doesn't mean you're always going to get them back. I just want to throw that out there. We do the best we can with what we have. Hang on, let me go back a second. Look at my notes. Um, Chances of survival diminish approximately 7% to 10% each minute until you defibrillate. Um, that's just something to keep in mind. 7 to 10% each minute that we're not using a defibrillator. Cardiogenic shock often caused by a heart attack. Heart lacks power to force enough blood through the circulatory system. Inadequate oxygen to body's tissue cause organs to malfunction. Recognize shock in early stages. We discussed this in our shock chapter. It is critical that we treat shock early. Congestive heart failure often occurs a few days after, or a few days following a heart attack. Um, Increased heart rate and enlargement of the left ventricle no longer make up for decreased heart function. Lung becomes congested with fluid, may cause dependent edema. So when we've got someone who might have some heart problems, we always look down towards their lower extremities for that extra swelling. Um, that's just a good sign that they're backing up in fluid, and that left ventricle isn't pushing out the right amount of blood, and we're actually backflowing into the lungs. You're gonna hear crackles. This is also where you might find that pink frothy sputum. If they're having a heart attack or choking, coughing stuff up, it indicates that there's blood in the lungs. Hypertensive emergencies. Um, Systolic blood pressure of 180 or higher. Common symptoms: sudden, severe headache, strong bounding pulse, and ringing in the ears. Um, Nausea, vomiting, dizziness, warm skin, dry or moist. Nosebleed, altered mental status, sudden pulmonary edema. If untreated, it can lead to stroke or that dissecting aorta aneurysm. Um, Transport patient quickly and safely. Consider ALS assistance. So that aortic aneurysm is weakness in the wall of the aorta, susceptible susceptible to rupture. Dissecting aneurysm occurs when the inner layer of the aorta becomes separated. Primary cause is uncontrolled hypertension. Signs and symptoms: very sudden chest pain comes on with full force. Uh, Different blood pressures. May be difficult to tell the difference between a dissecting aneurysm or and an AMI. Transport patient quickly and safely. We need to treat these patients. We should treat all patients gently, but we definitely need to try to be gently with them, because we do not want that aorta to rupture. It's already got a weak spot where it's separated. But if we get a tear in that aorta or a rupture, we're in bad trouble. So here's just some of the differences between that AMI and that dissecting aneurysm. So we're going to get into our assessment now. Scene safety: ensure the scene safe, follow standard precautions. We got to determine that nature of illness, obtain clues from dispatch, the scene, patient, family members, and bystanders. Form a general impression. If unresponsive and not breathing, begin CPR and call for an AED. Airway and breathing. Oxygen saturation is less than 95%. We apply oxygen via nasal cannula at 4 liters per minute. not breathing or inadequate breathing, 100% oxygen with a bag mask device, pulmonary edema, bag mask device, or CPAP if they're awake and they're able to use a CPAP. So this says 95%. I know every other chapter says 94% or higher is what we shoot for. Circulation, check pulse, skin, capillary refill, consider treatment for cardiogenic shock. Transport decisions, um, closest nearest facility, transport in a stress relieving manner. If they're awake and alert and you believe they're having a heart attack, this is an emergency, but we also do not want to get them any more excited than they probably already are. So just be smart about it. If you can, if you have the ability, go ahead and get ALS. Maybe they can meet you on scene, or you can rendezvous if you have a long transport time. Let's see, investigate the chief complaint, obtain that history using sample, and use OPQRST. We know what those are. Physical examination, so focus on cardiac and respiratory system, circulation, and respirations. Vital signs, measure and record the patient's vital signs. If available, use that pulse ox to get a better idea of what's going on. Reassess vital signs every 5 minutes when the patient's condition changes significantly. If you believe you're having a cardiac event, this is a time to reassess every 5 minutes. If cardiac arrest occurs, perform CPR immediately and AED when available. Reassess your intervention, provide rapid patient transport. So if this ends up being a full cardiac arrest, we're going to be doing CPR. We're going to analyze. Go ahead and call for ALS so that they can get fluid started and be pushing epi as needed. And yeah, provide that rapid transport. At this point, CPR, we're gonna be moving. It's a code. Ensure proper position of comfort. Give oxygen if indicated. Depending on your protocol, prepare to administer low dose aspirin and assist with prescribed nitroglycerin. Once again, know your protocols, what you can give and can't give. So aspirin prevents blood clots from forming or getting bigger. 81 milligram chewable tablets. The recommended dose, it depends on where you're at, can be 162 milligrams, which is 2 tablets, up to 324 milligrams, which is 4 of those tablets. My protocol says 324. They chew them up and swallow them. Nitroglycerin, it's available sublingual pill, sublingual spray, or skin patch applied to the chest. They can have once again, know your protocol. You can have 3 doses, 5 minutes apart, or until you have relief. The thing with nitro is you cannot give nitro if the systolic blood pressure is below 100 because nitro opens everything up. It will actually drop your blood pressure. And the last thing we want to do is bottom someone's blood pressure out and not have the ability to keep it up or to level it out. So if you're given nitro, if it's in your protocol, you definitely need to make sure you have ALS available because if their blood pressure drops, we need to be able to give them fluid to get that back up. So it relaxes blood vessel wall, increases blood flow and oxygen supply to the heart, increases the workload of or decreases the workload of the heart, and dilates blood vessels. So pretty much we are opening everything up and we're trying to allow a little bit of blood flow get past that clot. That's what we're trying to do. Side effects are decrease in blood pressure, severe headache. You guys know I'm big on educating your patient. Go ahead and tell them when you give it to them if they're awake, which I hope they are, because we're not going to give it to someone who can't follow commands. Let them know that it's going to give them a severe headache. Contraindications, so that systolic blood pressure under 100. If they've had a significant head injury, we don't want to give it. If they use erectile dysfunction drugs in the last 24 hours, because that erectile dysfunction drugs do the same thing that nitro does. It relaxes and opens vessels. Maximize our maximum prescribed dose has already been given, usually 3 doses. We don't want to give more than that. That's why we need to talk to our patient and we need to find out if they have taken nitro before we got there. For an ECG to be reliable and useful, cardiac monitoring. Those electrodes must be placed in a consistent position. Basic principles should be followed to minimize artifact in the signal. The guiding principle may need to shave body hair, rub electrode site with alcohol swab before application, attach electrodes to the ECG cable before placement, and then confirm the electrode placement. So here's just a diagram. There on the left, you've got a 4-lead. And these can be done in that order. They can be put on the wrist and down on like the calves of the legs. Then you go here to the right. You see V1 through V6. I mean, online, there's really no good way. If we was in class, I could show you in person. Um, I will tell you to pay attention to your intercostal spaces, and you can also use like the nipple line or the center chest area, kind of as a landmark, if that helps. Once electrodes are in place, switch on the monitor, print a sample rhythm strip. It's a strip shows artifact. Confirm electrodes are firmly applied and the cable is plugged in. Depending on your protocol, whether you can actually read those strips or not is based on your protocol. A lot of times you need ALS to be able to do that. Many open heart operations have been performed in the last 40 years. Coronary artery bypass graft, so chest or leg blood vessel is sewn from the artery to the coronary artery beyond the point of obstruction. So they go in, they make a bypass is what they do. They bypass that blockage. Or I can't even say that. The yeah, the angioplastia, it's a balloon is inflated inside narrow artery, coronary artery, which opens it up. Patients who have had open heart procedures may or may not have long chest scars. A lot of them will, but in today's world, they're changing. Um, there are so many new techniques out there that they might just have a little bitty scar. They might go in through a different area to reach that heart. So try to ask those questions, get that history. Treat chest pain patients who has had any of these procedures the same as a patient who has never had a heart surgery. Some patients have implanted cardiac pacemakers to maintain a regular cardiac rhythm or rate. So it's going to be located up in this area, and you're going to see just a mound. It'll be a circle or like a square, and you can feel it, you can see it. Um, talk to your patient, but you can also look for the scars. You can look for the pacemaker to give you a little bit if you need some history and they're not answering questions. Cardiac pacemakers maintain regular cardiac rhythm and rate, deliver electrical impulses through wires in direct contact with the myocardium. So it's hooked directly to that heart. Implanted under the heavy muscle or fold of skin in the upper left portion of the chest, right up in here. Cardiac pacemaker, this technology is very reliable. Pacemaker functions can cause syncope, dizziness, weakness due to excessive slow heart rate. Transport patient promptly. Automatic implanted cardiac defibrillators. Um, Used by some patients who have survived cardiac arrest due to ventricular fibrillation. Monitor the heart rhythm and shock as needed. Treat chest pain patients with these devices like other patients having an AMI. Electricity is low, so it will not affect the rescuers. It's tied in directly to that to that heart muscle. So it doesn't take the full voltage. So if it's shocking them, it's not going to affect you. External defibrillator vest. This is a vest with built-in monitoring electrodes and defibrillation pads worn by the patient. It's attached to a monitor. Uses high energy shocks. Do not touch the patient if device warns is about to deliver a shock. Vest should remain in place while CPR is being performed unless it interferes with compressions. This is a wearable AED. That's what this is. And then you've got your LVAD. Um, it's used to enhance the pumping of the left ventricle. Most common ones have an internal pump and external battery pack. Most patients will not have a palpable pulse. Um, Transport all supplies and battery packs with that patient. They will have a little battery pack that they carry on the outside, and it's literally like it's almost like a little water pump or a windmill. Um, the little pump that you put in a fish tank that circulates water and keeps things oxygenated, but it's in the heart. It's in that left ventricle. Cardiac arrest, the complete sensation of cardiac activity, absence of a carotid pulse, was terminal before CPR, and external defibrillators were developed in the 1960s. High quality CPR, early defibrillation, and access to advanced care can improve outcome. Cardiac arrests, respiratory arrest, nothing's happening. It's not working. It's in arrest. So we have to step up. This is where we do our CPR. This is where we do our defibrillating, and we keep that blood cycling. So AED we talked about during CPR, analyzes the electrical signals from the heart, identifies ventricular fibrillation, administers shock to the heart when needed. These things are universal. They've got pads that you plug in. The machine talks you through the process, and those pads have pictures on them, exactly where to place them. Um, there's really no way to screw this up. You turn it on, you plug it in, you put the pads where the picture tells you to, and you listen to what the machine tells you. AD models, they come in all kinds, so all require some operating interaction. Most have a computer voice that tells you step for step what to do. They're semi-automatic, but you still have to turn them on, which is that green button. And then when shock is advised, it will charge, deliver shock. You clear everybody, and you'd hit that little yellow or orange button, and it would deliver the shock to the patient. Advantages to the AED is quick delivery of a shock, easy to operate. ALS providers do not have to be on scene to use it. Remote adhesive pads, safe to use. And then large pad area. It's a larger pad area, more efficient shocks. Other considerations, not all patients in cardiac arrest require a shock. All patients in cardiac arrest should be analyzed with an AED. That flat line indicates no electrical activity. And then pulseless electrical activity usually refers to the state of cardiac arrest that exists despite an organized electrical complex. Early defibrillation. Few cardiac arrest patients survive outside the hospital without a rapid sequence of events. This is that chain of survival we discussed when we did CPR. So early recognition and activation of EMS. We got to see something wrong and we got to call 911. Immediate bystander CPR. Whoever's on scene has to start CPR immediately. Rapid defibrillation. The quicker we can get that AED on them, the better chance they have. Basic and advanced EMS. ALS and post-arrest care, and then recovery. So here's that chain, just to give you a visual. Kind of breaks it down there. Early defibrillation, CPR prolongs period during which defibrillation can be effective. has resuscitated patients with cardiac arrest with ventricular fibrillation. Non-traditional first responders are being trained in AED use. There are AEDs in schools and Walmarts, grocery stores, anywhere there should be or there could be a mass gathering, there should be an AED. Um, if you're getting an EMS, pay attention to this stuff. Next time you go to your local Walmart, try to find the AEDs. They're hanging on the wall. Um, ask your kids where they are in the school. Um, it's very important to know where these AEDs are, especially if you're going to be trained as an EMR, EMT, because you're not always going to be on that truck. You might run into a cardiac arrest as a bystander. ALS and post care or post arrest care. So continue ventilations, maintain oxygen saturations as high as you can get them. 94 or above is perfect. Assure blood pressure is 90 or above. Targeted temperature management upon arrival to the hospital, which is just saying we want them to be normal body temperature. Um, advanced assessment techniques and interventions. Then we go to recovery. It may take a year or longer for these people to recover from a cardiac arrest if we're able to get them back. Integrating the AED and CPR. So work the AED and CPR in sequence. Do not touch the patient during analyzing or defibrillation. CPR must stop while AED performs its job. The AED maintenance, maintain as manufacturer recommends. Read the operator's manual, document AED failures. Check equipment daily at the beginning of your shift. Ask manufacturer for maintenance checklist and report AED failures to the manufacturer and the U.S. Food and Drug Administration, or the FDA. Medical direction should approve written protocols for an AED. Continuing education with skills, competency reviews is generally required for EMS providers. So we've discussed this. In EMS, you're continuously being educated or gaining more education on updated events on what's going on. Your medical director will update protocols as needed. So we are always learning so we can be the best we can be. Preparation, make sure the electricity injures no one. Make sure everybody's clear. Do not defibrillate patients in a pool of water. And do not defibrillate patients touching metal. Preparation, carefully remove nitroglycerin patches and wipe with dry towel before shocking. Shave hairy chest to increase conductivity. Determine the nature of illness or mechanism of injury. Call for ALS assistance in a tiered system. Um, we can also use things like duct tape if we have to. If they're super hairy and you can't get the razor on them, grab duct tape. If you've got an extra set of AED pads, put them on there and rip them off to clear that hair out of the way. We've got to have good contact with the skin for an AED to work properly. That is just kind of a protocol. That's what they look like. It's taking you step by step. You answer the question yes or no, and you keep following it down to the bottom. Beginning chest compressions and attaching AED as soon as available with witness cardiac arrest. Follow local protocol for patients' care after AED use. After AED protocol is complete, one of the following is likely. Pulse will be regained, no pulse regained and no shock advised, or no pulse regained and shock advised. We just keep going. Um, know what your local protocol is. Wait for ALS to continue shock and CPR on scene. If ALS is not responding and protocol agree, begin transport when the patient regains a pulse. 6 to 9 shocks are delivered. AED gives 3 consecutive messages every 2 minutes of advising no shock advised. So if you are going to, if you've been doing CPR for 20, 30 minutes, you're getting no shock advised. ALS is not responding. If it's just you as an EMT, you're the highest level. Call your medical direction and ask what more you can do. cardiac arrest during transport. So we're transporting someone goes into cardiac arrest, stop the vehicle, begin CPR if AED is not available, immediately available, call for ALS support, analyze rhythm, deliver shock if indicated, and resume CPR, continue resuscitation per local protocol. Conditions with ALS personnel, if AED available, do not wait on ALS, notify ALS of cardiac arrest. Do not delay defibrillation, follow protocol. It's reoccurring. We follow our protocol. You have to know those protocols. Monitor for respirations. Provide oxygen via bag mask device at 10 breaths per minute. Um, Maintain an SpO2 of 95 to 99%. Assess blood pressure. See if patient can follow simple commands. Immediately begin transport if ALS is not en route. So this is if we get them back. This is if we get ROSC, return of spontaneous circulation. Um, okay, so before we hit that, you work a cardiac arrest and you get them back. Um, we sometimes they're going to wake up, and within a few minutes they're going to be awake. Um, so in that case, we might have to remove like the OPA. We might have to remove the MPA. They might be breathing on their own. Um, they are going to be in extreme pain if we have been doing CPR. Just be prepared for that. If it was an early or if we caught it early, we recognized it early, and we started CPR within that first 30 seconds to a minute, um, and we get them back fairly quickly, there might not be any change at all. If they were down for an extended period of time and they went without that oxygen for a while and without that heart beating, there could be some brain damage. So just mentally be prepared. The outcome we all want is we want ROSC. That's why we do this job, is for that moment when we can actually say we saved a life, we brought someone back. But just be prepared and don't expect ROSC on every single patient, because it's not going to happen. So all of the following are common signs and symptoms of cardiac ischemia, except so chest pressure, shortness of breath, anxiety, and restlessness. Headache, I'm going to say probably not. While palpating the radial pulse of a 56-year-old male with chest pain, you note that the pulse rate is 86 beats a minute and irregular. This indicates the dysrhythmia. D. Let's see. 56-year-old man has an acute myocardial infarction. Which of the following blood vessels became blocked and led to this condition? Well, we know pulmonary is lungs, so it's not those. So it's got to be a coronary vein or a coronary artery. Probably gonna be B, coronary artery. Major controllable risk factors for an AMI, acute myocardial infarction, include, now it's a controllable. So which one of those can we control? I can't control my age. I can't control my family history. I can't control what sex I was born. So C, cigarettes. I can control if I smoke or not. The patient with cardiac arrest, secondarily to ventricular fibrillation, has the greatest chance of survival if I don't know how much I can stress this. Uh, that defibrillation is provided within 2 minutes. So C. We have to have that defibrillation. You can save a life with CPR only. You can. The outcome is so much higher if you have that defibrillator. A 59-year-old woman presents with chest pain. She is conscious and alert, but her skin is cool, pale, and clammy. Your first step in providing treatment should be so she's conscious. I'm not going to put the AED on her. Um, I need to get blood pressure before I do nitro, which would be involved. I could do my vital signs, but she's showing signs of shock, and we treat shock early. So we are going to apply oxygen. If a patient with an implanted pacemaker is in cardiac arrest, the EMT should, it's in your chapter if you read your chapter. We place our AED pads, but we place them away from the implanted device. C. The main advantage to of the AED is it's going to be D, all of the above. It provokes quick delivery of shock. It's easy to than performing CPR, and there's no need for ALS to be on scene to use the AED. After administering a nitroglycerin tablet to a patient, the EMT should remember what it does. It drops our blood pressure. We don't want to bottom a patient out. So it's going to be B. We reassess that patient's blood pressure every 5 minutes. If it's not helping, we can re-administer if our blood pressure is still high enough every 5 minutes up to 3 doses. Nitroglycerin is contraindicated in patients. I think I hammered that one home enough. It's A, if their blood pressure is below 100 or if they have bleeding from the head trauma. We don't want to give it then either. So, guys, thank you for sticking with me. I will catch you on the next one.